I'm Mary Chambers, the head of public and community engagement at the Cochrane units in Ho Chi Minh City, Vietnam, but also Indonesia and Nepal. So Cochrane is a research group with a vision to do scientific research on infectious diseases that are of importance in our host countries. And as Gary said, we're part of a wider Wellcome Trust Asia and Africa program of research centres. So I'm going to present a brief description of the Vietnamese national response to COVID-19, and then a few examples of how our engagement teams, which are embedded in these academic research institutes in Southeast Asia, how they're working to engage the public about the pandemic. So I wanted to start with a brief look at the Vietnamese response to the COVID-19 pandemic, particularly because in academia there often seems to be this asymmetry of knowledge transfer from global north to global south, or between upper income countries to lower and middle income countries, whereas I think there's many lessons that can be learned from the approach that Vietnam has taken to the pandemic. And I just wanted to reflect on that before I go into some of the examples of our work. So Vietnam is a country of about 97 million people. It borders China in the north and Laos, Cambodia to the west. And over the past 30 years, Vietnam shifted from being one of the world's poorest nations to ranking as a low middle income nation. And the current COVID-19 case overview is shown there on the right of the slide. And to its credit, Vietnam has had 332 confirmed cases of COVID-19, but with no deaths. And that's really why I wanted to just briefly go through how Vietnam has managed this and what its national response has been. So the first case of COVID-19 in Vietnam was on the 23rd of January. They very quickly assembled a national steering committee for COVID-19 response, which put into place mass communication measures. Sometimes these were well ahead of the WHO announcements. They put into place contact tracing and testing, and on average, Vietnam's tested 800 contacts per positive case, which is the highest ratio in the world. The responses included mandatory but free 14-day quarantine in specific quarantine centres for tens of thousands of people. There's been school and university closure and progressive flight restrictions. On the 11th of February, in response to a pocket of cases, St. Loi village in the north was quarantined for 20 days. There was a whole nation lockdown between the 1st and the 22nd of April, with the closures of businesses and internal travel. And we have had no recorded community transmissions since the 15th of April. And so the government has gradually lifted internal restrictions apart from the external borders. So I just wanted to highlight some of the public health lessons that I think can come from this national response, and then tie that down to the way that we've focused our public and community engagement within this context. So firstly, the country was able to respond very quickly, and perhaps this is because of previous experience from other epidemics and pandemics such as SARS, which was 17 years ago, or H5N1, which both had their epicenters in this part of Asia. Another reason that Vietnam could respond so quickly is because of the very strong infrastructure of community health workers who were very quickly re-employed or redeployed to spread the public health messages and to conduct the contact tracing. And there was a unified message about protective health measures and restrictions. And so even though this has been a very top-down and at times quite drastic approach to the control of the disease, there's been a very widespread acceptance of the restrictions and a trust in the government and the health services. So that trust is demonstrated in this graph, which is from the YouGov website, which represents percentage of people in each country who think that the government has handled the issue of coronavirus very or somewhat well. And as you can see, the Vietnamese respondents have overwhelmingly approved of the national handling of this pandemic. So I think this trust becomes particularly important when we look with hindsight at, say, the Ebola outbreak in West Africa. And analysis of the public views in Liberia showed that low trust has a strong correlation with low compliance and uptake of control measures. Interestingly, however, that low trust was not associated with less understanding of the disease or of transmission. And then in response to the Ebola outbreak in West Africa, the WHO has published a number of guidelines about epidemics and pandemic preparedness. And one of them outlines the essential place of public and community engagement to build trust. And 3 ways that are identified in these guidelines to build trust include, firstly, ensuring that there's dialogue between experts and public and transparency about the public health or scientific approach, that there are collaborations to find solutions, and that knowledge transfer can empower communities to care for their own health. So based on these 3 approaches, our Oak Crew public engagement team have designed a number of engagement activities that involve the public in our 3 host countries, Vietnam, Nepal, and Indonesia. And so for the rest of my talk, I'm going to briefly share a few examples of our engagement activities. So firstly, we've tried to create online platforms because obviously face-to-face engagement has been restricted. So we've created online platforms that have enabled the public to speak directly to our experts, both doctors and scientists. So in Indonesia, we've partnered with The Conversation, which is an online evidence-based newspaper, to conduct online webinars. In Nepal, we're about to start holding public online tea talks because the Nepalese like to drink tea. And in Vietnam, we've set up Ask the Scientist chats to link school children with Oak Crew researchers. And just a few days ago, we co-hosted a Livestream Q&A with the British Embassy in Vietnam, and 2 of our Oak Crew colleagues joined the ambassador in a Q&A. And what was very noticeable was the constant string of questions from the public throughout the session, demonstrating a very real hunger for people to speak to experts about the pandemic. So in a different project, we are inviting members of the public to submit digital diaries to tell us about their experiences of COVID-19. And these diaries might be in the form of an Instagram post with a photo and a caption, or weekly short videos. And this is a cross-site project that's being coordinated by a colleague of ours in Nepal, Dinesh Diakota, and his company, Media for Development. And then to meet the 3rd aim of knowledge transfer, we've got a media monitoring project to try and identify fake news and misinformation that is circulating and trending in our communities, mainly on social media. And then we're aiming to respond with positive evidence-based health messages. So these health messages are taking quite a different form in the different contexts. So for example, in Jakarta, the Oak Crew team are writing science-based articles for newspapers, online newspapers. In Vietnam, we've translated the WHO Mythbusters and are circulating those on social media. And in Nepal, the team have created public health posters, which are being physically distributed around communities. And finally, our team, and in particular, Ms. Ragil Dien from Indonesia, has been creating a number of short animations about self-care and protective behavior, and we're sharing these on social media. So this is ongoing work, and we haven't evaluated any of these activities yet, so I can't really share results or reflections. But this is how we're trying to involve the public in these countries, and I hope some of these examples have been of interest. And this work is being carried out by a large and a wonderful group of people in the Oak Crew PE teams in Vietnam, Indonesia, and Nepal. And you can see more of their work at this website here. So thank you for listening.